Hello, everyone, and welcome to our live recording of Bright Spots in Healthcare, produced by Shared Purpose Connect. We bring leaders together to not only inform you, our audience, but also unearth bright spots, successes at health plans, hospitals, and other healthcare-related organizations around the country. Our goal is to identify as many bright spots as possible so that you can determine if the ideas shared during this very episode can be applied at your organization. We believe this approach of finding a bright spot and cloning it is the most effective strategy to improve healthcare in our lifetime. A quick public service announcement. If you have not subscribed to the Bright Spots in Healthcare podcast, if you're watching live right now via Zoom or you're watching our video on YouTube, go to your favorite podcast app, type in Bright Spots in Healthcare, press subscribe. You will get episodes downloaded to your device basically every week, featuring some of the smartest, innovative people like the ones you see in front of you today in our industry. These are where the ideas come from. Don't worry, they don't come from me. They come from all these great guests that come on the show. So I encourage you all to help make healthcare a better place and subscribe to Bright Spots in Healthcare. Our topic today is reimagining your provider network strategy. We've got a really, really good roundtable put together for you today. We're going to put their bios or a link to their bios both in the show notes if you're listening on the podcast, and also the show description. I shouldn't say show notes, show description. Also in the live chat here, if you're here with us via Zoom, so you get a sense of the great experience and expertise you're going to benefit from over the next hour or so. So our panel is in alphabetical order: Steve Anderson, aka Steve number 1, VP of Provider Contracting and Network Administration at Blue Cross and Blue Shield of Michigan. We have Jim Brown. He's the Vice President of Market Operations and Strategy at Highmark Health. And Steve Levin, aka Steve number 2, the Chief Executive Officer at Quest Analytics. Quest Analytics happens to be our partner in crime and sponsor for today's show. If you don't know about Quest Analytics, and you probably do, but they bring unrivaled provider network solutions and services into the market. They are the innovation leader in enabling risk-bearing healthcare organizations to manage, measure, and monitor provider network performance. So Steve has a ton of expertise he's going to bring into this conversation. And I will tell you more about Quest Analytics later on in the episode, during the episode. But if you want to check them out now, questanalytics.com is where you can find a lot more information. So I've divided today's discussion into two halves. And incidentally, folks, if you want to help me moderate, you can use the Q&A module and submit your questions there. And Gene, we're our producer, and we've got a team looking at those questions. Some of them we may answer asynchronously and just post them, and some of them I'll integrate into the flow of today's discussion. And like I said, that will be a great help to me as moderator, take a little bit of the load off my shoulders. So feel free to ask away. We're going to start the first half of today's discussion with the what? Strategy. We're going to discuss strategy, and then we're going to get into sort of the tactics and the how. And that's how we're going to divide up the 55 minutes or so that we have. So let's start here. Health plan CEOs and executives are constantly adapting to regulatory and market changes, as well as different innovations in healthcare technology, different innovations in the biopharmaceutical space. So I'm going to bring in Steve Levin, CEO of Quest Analytics. Steve, how should CEOs and other leaders, think about provider networks and integrate provider network thought process into their overall strategy, let's say over the next 18 to 24 months?
Thank you, Eric. So first off, I want to correct a few things earlier said. I think that Jim Brown and Steve Anderson bring so much content here. I'm just going to try and hold on and hold on to the conversation. Second thing I want to say is, Eric, I appreciate, I think your point about bright spots is so true. It's so easy in this business to point to the things that aren't working or the things that are hard, but people actually, I believe, are motivated for good. And so finding the bright spots and figuring out how to use them is really powerful. It's something I always believe, but I think organizing around is great. So I want to say thank you to that. Now I'll come to your question. Sorry for, this is going to be a long 55 minutes when the very first question, he ignores it. Look, networks are, these are like the fundamental part of healthcare. network is not just a list of providers. Networks is, it's literally the foundation on which all healthcare runs. Every single constituent in the healthcare ecosystem is part of the network. Providers are kind of participating in it. Payers or plan sponsors are organizing them. Regulators have to ensure and oversee them. And obviously members experience them. And they're not a list, right? This is not like you can think of this, people think, oh, it's just a directory list. It's not. It's laid out across a geography. It's who's close, who's far, who has handicap ramps, who doesn't. It's a really textured and nuanced asset. And as an asset, it is core to the business. It is hard to have great healthcare with a poor network. And in some ways, I think that we need to turn to your framing. It's the network reflects your business. Like, what are you trying to accomplish as a plan sponsor? Even if you're like a commercial plan being sponsored by an employer, or a Blue in a Medicaid or a Medicare plan, like, what is your business strategy? How are you choosing to engage your members, your community? What's the type of experience that you want them to have? How do you want them to access care? What's the design of the care package over time, right? This is a long-term commitment we're making. The network needs to reflect that. And it's interesting, healthcare, you mentioned earlier, sort of changing dynamics. Networks are a living beast. Doctors come in, they go out, institutions merge, they break up. It's so every day, sort of the network is an evolving asset. We need to build our networks that reflect the business. It really, really matters. And you can't, in the old school, it would be, let me just build a network to get relevant. I'm going to get compliant, or I'm going to pass the adequacy test. That's not a recipe for victory today. The business is too hard at all levels. We need to kind of reverse the other way and say, what do I want them to look like? And how am I going to get that? And we need to sort of, you can go from like the coarsest set of content, like what's my NPES file out there? Who are the docs in the market? To much more sophisticated and sort of, I think some of the brighter spots, to use your language, or people who are starting to think about, what other content can I bring into this discussion? How else can I profile or enrich the provider, the facility? How can I understand more about this delivery, my delivery choices? And also, how can I understand more about my members and the members' needs, and so that these two can be matched? So it's probably more than you were hoping for on that, but let me.
I like that a lot. I'm going to ask you a quick follow-up, because I'd like to go. I know when we were sort of, let's say we were prepping,
Yep.
you had mentioned sort of like there's three kind of keys or levels to taking, or
this data piece, like
right. So what are those three levels to taking that network strategy to the next?
So there are, I think that, what we have seen, and we've seen people in the market sort of doing sort of the continuum. So the very basic is, we're just going to, we'll take the NPES file, if it's, we'll take the Medicare Advantage supply file as the government publishes it, or we'll take sort of a public listing of providers and facilities. And that's sort of like the basic. Imagine this being like the least amount of work. But if you want to really build smarter, those files are challenged for their depth and sophistication. And so it's not a surprise. It's known to everybody that, upwards of 30% of the data in some of these files is sort of inaccurate. The locations don't exist anymore. The provider has moved to a different specialty. They're not even participating in that line of business anymore. And so literally the number is actually like 2 or 3% of the data changes every month. And so the kind of the evolution arc, or the stages you're talking about, is sort of what we think about is sort of the public. We think then about sort of the not so public, and the ability to bring, there's a platform we run called Better Doctor, which is around direct provider attestation. Provide millions of doctors and providers are updating their content in a kind of a portal and a platform, so that we're able to take the public, move it up to a much higher fidelity location. And then you can go beyond that. You can start applying all sorts of decision analytics and machine learning. But the goal here is to kind of move from the basic to the better to the best.
Okay. So public, not so public, and then maybe the curated view of publicly available.
Correct.
So I want to talk, I know provider network strategy, albeit important, is a fairly tired topic for many of those listening, but there hasn't been a lot of major innovations and changes on how to optimize provider networks to meet all of your consumers, all of your members, while also maintaining a healthy business, right? So I'm going to bring in Jim Brown, who is I don't know if this is a HIPAA violation, Jim, but a Bengals fan, Browns fan.
Browns, that hurt me in my heart.
All right, Browns fan living in Pittsburgh. Jim, how are you thinking about provider networks, and what is a strategy at Highmark that you see that is working?
Yeah, Eric, I'm going to pull a bit of a thread that I think it's Steve number 2 mentioned, which is the word asset. We like to think of our provider network as one of the greatest assets we have as a payer to help bring value, experience, outcomes to our members and clients. However, provider networks have for a long time been thought of as almost a sacred cow, right? Like, it's very hard to sort of touch or maneuver around the provider network because access to doctors has been so fundamentally important to the story of what a provider network is. We're beginning to emerge into an area where, as an industry, we've pulled kind of the low-hanging fruit, I think, around disease management and utilization management to try and curtail the rising cost of care. And newsflash, we haven't really curtailed the rising cost of care. One of the last sort of horizons to be able to do that is this asset of our provider network. And what can we do collectively to use that provider network to get better outcomes for the patients and members who are using that network, better experience through that sort of treatment of, just sort of maintenance work around the provider network, where you might be adding 1 or 2 doctors a year, or you have a member who calls you to tell you that a provider is no longer active in a location, so you remove 1 or 2 provider locations at a year. We're left with an environment where our network is bloated. We have inaccurate directories that don't represent true service locations, and we're not optimizing performance for our members and our clients. So here at Highmark, we've been really working hard to begin to collect and curate information together. Information is just information. You need the insight to really create what we're thinking of as the art of possible, Eric. What can we do with this network asset that would provide value? And then how do we tell the story around that value that we're creating, leveraging that asset going forward? So it is a multi-stage process. I think that art of the possible, while I'm a reformed actuary, and I like to think of it as a math exercise, meaning is a discrete, you can use a number of different metrics and measures to define what a provider might look like relative to their peer. It's not as simple as a math exercise. It takes mind share shift within the organization. It takes organizational buy-in, and it takes strong communication and transparency with your provider community as to why you're making the changes that you're making.
Okay, so the art of the possible. So you're thinking first of the network as your greatest asset, or one of your best assets, deliver access, outcomes, experience, etc. And you need to think of your network strategy not just as fixing up the database and maintenance. How do you make the experience and outcomes better for the patients that you're serving, for your consumers, and how to best leverage the asset beyond that? One of the keys, obviously, is making sure that that asset is fresh as far as not only the data that you traditionally put in there, but also different data points. We'll get into some of that later. And it just has to be a mind shift, right, at an organizational level.
That's exactly right. A little bit of bravery necessary.
Okay, I like that a lot. So I'm going to bring in Steve, number one, Steve Anderson, VP of Provider Contracting and Network Administration at Blue Cross and Blue Shield of Michigan. Steve, the key to any network provider strategy is aligned incentives between payer and provider network. How has Blue Cross Blue Shield of Michigan gone about aligning incentives and building such a well-known, tremendous provider network in the state of Michigan?
Yeah, thanks for the question, and go Lions. We've been on a 20-year journey, Eric, with especially our primary care physicians, with a pay-for-performance program that we like to call Physician Group Incentive Program. Now, we didn't pay a whole lot for that money, so don't criticize it. A whole lot of money for that name, so don't criticize it too much. PGIP is how we acronym it. But it started with really just simple pay for participation, inviting them to the table, paying them for their time to be there. Bring your administrative partners. We're talking to actual physicians, and let's imagine the future. How do we create the modern primary care office that goes beyond just treating and releasing, and more to what has become the primary care medical home, patient-centered medical home. And so over those 20 years, we have poured enormous amounts of money into that program, and we've taken it from participation to performance, and now really to risk. We have nearly a third of provider reimbursement tied to metrics that are driving affordability, metrics and incentives that are of interest really to the collective, but especially to the insurer trying to win business and retain business. So 20-year program. If you aren't started, you better get started now, because it does take time to win over the hearts and minds of that, especially that primary care segment of your network.
Okay, I wrote a quick summary there because you mentioned 20-year journey. You used the term exorbitant or tremendous amounts of money. So we got to double click there so everyone feels like that maybe it's possible at their organization, maybe it's not, depending on the answers to the second question, which is like, what does that mean, exorbitant or tremendous amount of money? But just to summarize some of the things that you've evolved into, you've went from pay for participation to pay for performance to now some sort of, I don't know, risk arrangement where a third of the provider reimbursement is tied to metrics that are of collective interest, as you called it. So did I summarize that okay before we get into
Yes.
like, and what is tremendous amounts of money?
So we're a big plan. So this is the land of the big numbers, right? We have 5.5 million members, 3 autos, a number of suppliers out there. So you can look at what we spend. It's nearly $20 billion across hospitals, physicians, ancillary. So if you think a third of that is physician.
Annually? Is that annually 20 billion?
Annually, yeah. Yep. So a third of that, $400,000, $600,000 million on physicians. So in the incentive space, we have a number of mechanisms that are directly into claims payment. So those dollars go directly to the physician. And then we have another pot of money that goes to sort of the physician management. We call them physician organizations here, but keeping those entities funded and managing their collective set of physicians. So again,
let's get into the POs later on. I have that noted, but keep on going. If you're
yeah. So 20 billion, about a third of that spent on the physicians, and about nearly 20% of that, again, trying to do the math here because I got an actuary on the line, 400 to 500, good to hear, 400 to 500 million in incentive programs and fee schedule enhancements.
Okay, great. I will get into more of this later on. I do have this pinned to come back to it. I want to dovetail on something that Jim Brown was saying in The Art of the Possible and bring in Steve Levin, Quest Analytics. Steve, can you illustrate, like, let's get some examples, some bright spots. Yeah. Can you illustrate by real example how a health plan may be applying some of these new provider network strategies, some of the art of the possible?
Yeah. So, by the way, I love Steve and Jim. You guys are just like, where you're going is about thinking about the right people in the networks for the right end. So here's an example, Eric. Somebody was looking to expand in Medicaid. They had a couple different markets. They wanted to participate in the Medicaid market. And their view of the problem was, I need to understand what's the right core to start from. Because the old approach, or kind of a legacy approach, would have been, let me just anybody take my paper, it's what I want. And then you sort of like, you have this kind of virtuously downward cycle suddenly. And it was so much easier to say, like, what do I think about the membership that I'm going to kind of acquire, the context which I'm going to operate, the business model. Who do I really want? What's the attributes of my PCPs, to borrow from Steve? What are the attributes of my specialists I want? And sort of, how do I think about my Medicaid proposal as opposed to other competing Medicaid plans? And so they designed these sort of principles for the types of care settings, care participants they wanted. And they built a pretty smart supply file, right? To the point earlier, they took the public, they took it curated, and they started enriching these files. They added some quality scores, be that scores that they had curated their own. They had to extend it because it turns out that no scoring system is sort of utopian. You need to sort of have a couple different next to it, and there's lots of different brands out there. But they built an enriched view of the providers, even understanding things like, to what extent do we know if they've got language competencies? It's an uneven, there's a lot of hard data in here. So it's not like you know everything about everybody, but even if they got 30% of them with some level of, I have some view of their language skills, that was really helpful, because they could start marrying that up to the member experience, the members they were looking at, like, what are their language mixes? And that public data is pretty well available. And so they started, as opposed to just taking anybody that would take the paper, they built towards what's the type of network I want, what are the attributes of those providers, and now let's figure out what that core is. And ultimately, that network's not sufficient. It's not like you can pick this, you can build 100% adequate and have 100% coverage, but it's much easier to sort of start from the really good and add down than it is to start from the bottom and try and raise the boat.
Examples of some of the attributes you're looking at?
Member side, lots of members was things like income, education, safety, transportation, some really basic things that I think COVID and social determinants have raised about the membership. And on the provider side, it was literally language skills. It was specialties. It was attributes of their service location. Are they near a bus line or a train station? Like, and ultimately there's more coming, right? So I think that the future in this space of what sort of attributes you want is going to get really rich. And but right now we're kind of walking before we can run in some of these attributes.
Like that. Yeah, Jim, I'm going to bring you back in. By the way, PSA folks, we are running a little bit behind schedule. There is a question, Steve Anderson. Tell me if you could answer this by typing it out. If not, I'm going to bring you on right now. So sorry, guys. What sort of tools or programs are you trying to implement to help incentivize those shared savings within the provider system that you talked about just earlier? Could you type that up, or would you rather answer it right now?
Type it up.
Awesome. That's coming to you guys through the Q&A module, folks. Keep your eyes open for that. Thank you, Steve. Jim, well, we talked about your strategy, high level, the art of the possible, but let's talk about your provider network strategy specifically. What are you doing today?
Yeah, and I keep dovetailing off of what Steve too says, but it's a perfect segue into kind of what we're thinking and what we're doing. And so again, I'll go back to the art of the possible. We think it's really important, and I like Steve's analogy of building from the bottom and building from the top. You need to know what your network represents today and how it stacks up, both relative to what your goals might be from a network design perspective, and competitively what your network looks like versus who you're comparing to. And then
let's look in the mirror.
Yep. And then to the art of the possible, what is the optimized network that you could design based off of the framework of performance metrics that are really important to you? And that framework can change depending on the geography, line of business, the year, the day of the week, who you're talking to. But we think of it in sort of 5 major areas or categories, Eric, that we think captures most of the performance variation. We really need to have this at a distinct provider level in order to compare back and forth. And then you kind of roll it up beyond provider to an office level, to a contracted entity level, to a health system level. But when we think about those variables, we often start at sort of an episodic total cost of care. As you know, I referenced earlier, trend and medical expense continue to escalate. One of the largest motivating factors is affordability. And so that total cost of care is often one of the most highly prioritized variables. Obviously, quality goes along with that. So the experience and quality that our members and clients might be able to achieve. Equity is becoming increasingly important. Does our provider network represent the members and patients that we have in the geography, or there's something missing from an equity perspective? Availability could be as broad as, does this provider still actively treat patients at the location that's represented in our network? Or it could be as maybe sophisticated as, how long would it take if a member called this provider to actually get in and see that doctor for a dermatology? Because it always uses dermatology because it seems like it's an 8-month wait regardless of where you call nowadays. And then the 5th thing that we look at is sort of structural alignment with the provider or health system that we're looking at. So could we devise a structure where we could have a competitive advantage relative to other payers through like-mindedness or alignment and structural sort of integrity within the process? So we kind of bring all of those variables together. What I'd say, Eric, is oftentimes that we have internal information that we can leverage, but it's not sufficient. We often look for partners or work with external entities to sort of broaden each of those variables from a completeness perspective. Or I'll use an example. If we're looking to go into a new geography or a new segment or a line of business where we don't have data, we can't really rely on what it might look like in Pittsburgh versus another geography. It doesn't work that way, right? The providers aren't the same. So we work with a number of different partners who have established kind of really high fidelity data and insight in this space.
Okay, I'm going to do a quick little summary, then I have a follow-up that I'm going to let you warm up for.
Warming up.
Yeah, because I'm going to do a little stall with a live read. So yep. Performance analysis, you listed 5 things. I want to make sure everyone captured those. Episodic total cost of care, quality of care, equity, availability, and then you called it structural alignment and competitive positioning, which is interesting. That's what prompted like this idea for this next question, because I'd like to know, when you're thinking about, remember Highmark's in Pittsburgh, you could Google this, but there may be another health plan and medical system in Pittsburgh that maybe Highmark competes in. I'd like to go into like how you use that competitive positioning in that network in a moment. So that's the question I'm going to come back to in a second. So real quick, folks, I told you at the beginning, our partner for today's episode is Quest Analytics. They're really the perfect partner for a topic like this. I just want to tell you a little bit more about them because they're such a good fit for this content in this episode. Quest Analytics is a software platform that empowers you to meticulously analyze, expertly manage, and impeccably report on your provider network's adequacy and the provider data accuracy across your entire organization and all the lines of business. So almost just what Jim was talking about. And you could trust them. CMS does. And so do, and their CMS is just one of 8 of the nation's largest health plans that leverage their software and services, not to mention other state regulatory agencies and many of the nation's leading healthcare systems and provider groups. They manage, measure, and monitor health plan network performance. So together, We can all elevate the health of communities across this nation. They also empower health plans to clearly differentiate, just like Tim was saying, and position themselves in the marketplace to a vastly superior provider network. My words, not theirs, coming up, but I kind of, to simplify things, and Jim and I were kind of debating who came up with this. I'll give you credit, Jim. Think of them as the kayak for physician quality and accessibility data, where they aggregate all the data from all the different sources and companies that you know and trust into one platform. And again, learn more about them at questanalytics.com. Actually, let's do this. I'm going to put my producer on the spot. If you want to talk to Steve or someone on the Quest Analytics team, just to ask them more questions about this, see if my metaphor is correct. Jim's metaphor is correct. If it's wrong, if it's right, it's my metaphor. Why don't I'll introduce you to them and help you set up a one-on-one meeting or one-on-two meeting with them. So, Gene, if you could throw up a poll, and I will personally introduce anyone that says yes to Steve and his team, and then we could decide through scheduling who's meeting with who. But and you could get me out of the way, put me into BCC once I send you an intro. So if you want to check out Quest Analytics and meet with them, we'll put up a poll right there. Let's come back to you, Jim. Let's talk about competitive differentiation. Let's talk about the greater Pittsburgh market. And let's put the art of the possible into practice. How can someone like you or people just listening around the nation rethink the provider network to drive the better access through these subpopulations and win in a commercial situation?
Yeah, I'm going to dovetail this in, Eric, with a question I saw in the chat, which is kind of describe more about that structural alignment. So we think very strongly at Highmark about providers as a partner in the healthcare journey, not as an adversarial component to the payer relationship. And so we think it's fundamentally necessary for us to partner with providers to address the cost issue that we have. In doing so, that requires a number of different alignment or things that we work together on, be it administrative simplification through things like gold carding, where we can try and eliminate the burden of prior auth. But that takes some amount of leap of faith on the provider side, because we have years and years of animosity built up from the payer side. So it takes a lot of coordination and a lot of working together. In an environment like Pittsburgh, where you have sort of a multi-pronged delivery system, two dominant payers, two dominant health systems, both kind of vertically integrated, there's an opportunity to work with the provider system around volume, and in addition to value. So through kind of network construct and network design, you can work together to actually pull more volume into the health system through a partnership effort that provides more value and outcome to the patients and the community as a whole.
So what are some of the, before we leave this topic, like if people are taking notes here, like what are the key takeaways they should be writing down here about?
Yeah, from my perspective, key takeaways are data and insight are absolutely key in when you're thinking about a provider network strategy, and having the ability to see what's happening at a provider level relative to their peers, including kind of referral patterns. Steve and both Steves mentioned kind of the importance of PCPs in the delivery system. As you're sort of thinking about curating access in a network, you can very easily create a bad outcome where you might remove specialists, or you might remove a health system, leave a group of PCPs in your network who commonly refer to those specialists or health systems, and then you create a situation where a member ends up in an out-of-network situation. You really need to think holistically about your network as that asset as you're creating and designing it around it. The second thing that I think is really important, Eric, is the connection of that data and insight into kind of one seamless environment or platform. And we might talk about this a little bit later, but we often, as an industry, and my company is no different, we have disparate information. We have reams and reams and reams of information, but that information is housed in different places or different sections. And we waste time just connecting that information together in one viewpoint. And what should take a couple hours as we're making a decision around a provider participating in our network, what does that do to quality? What does that do to cost? Those 5 variables we were talking about. It could take weeks or a month to actually get all those information points together, because those answers are derived out of different sources of information. So having a platform that brings that all together is really, really important. And then the third thing that I'll sort of reinforce, and I mentioned the word earlier, bravery. or courage. This is not an easy process. It will be iterative. You will disrupt kind of how you've typically talked about your networks. And so I think it's really important to have that organizational buy-in, that this isn't going to be easy. This is a challenging road that you're going down, but the outcome of better care, higher quality, lower cost is worth the proverbial juice is worth the squeeze.
And as far as capturing all that data, you're not doing that yourself. You're using.
Yeah, we use our own data, we use other data, and then there are different systems out there that can collate all that information together for you as well.
Okay. Steve L, like, how do we go about building a provider network? How do you execute on some of the ideas that we've been shared by Jim and Steve so far?
Right. So look, there's a platform you need. Like, there is a tool that's able to kind of help you put all this stuff into a visual construct. And because it's time and distance based, location based, it's more than an Excel spreadsheet, so it's complicated. But there's a tool. But to go with that tool, you really need to have, two things. One is clarity of purpose. Like, what are we trying to do in the business line here? What's our business strategy, and how do we think about, how do we convert that into some rules or guidelines for people? And secondly is a good view of the market supply file. So who are the providers and the facilities and the groups in the market? And so some basic principles, Eric: average down versus average up. Identify the really distinctive people in these markets and say, I need those. Jim mentioned it earlier, which is, providers are there's a natural sort of stream and flow through their provider. PCPs have certain specialists work with certain facilities. Like, understand those flows, really important. So, in order to do that, you need a pretty rich view of these providers. Like, this is the people I want. What do the flows look like? Why do I want them, right? Like, so Jim mentioned it. You need to have a point of view on efficacy or quality or cost. I think Steve mentioned it. You want to get people who've played in a risk model, right? Somebody who's got experience in participating in a risk or a shared environment, years of it learning. He mentioned 20 years at this. So those people, you can get a sense of, oh, this doctor or this group's been in one of these relationships. Understand the membership. Know where the members, who the members are, or the ones you want, or the ones that are there. And understand like who's the 5-star. Get those. Understand the competitive context. Who are the ones that, like, all your competitors have that they're 5? I want those too. I want to be competitively, great. You can't, as Jim said, you can't get everyone to be exclusive, but like, I want the big hitters. I want the ones that are good, because I want to be at the competitive. And then lastly, it takes time, and you start with the core and you build over time.
Hey, Steve, I'm going to ask you a follow-up from the audience, because I think you touched upon it, but I think we're looking to get a little bit deeper. Like, provider data and quality and appropriateness, cost, SDOH data, all those products, and it's crowded space.
Yeah.
And Jim and Steve A, you could jump in on this too, because how do your teams, or how would you advise teams listening to evaluate, partners? I know you're a little biased here, to ensure that the data is valid and useful. Yeah,
actually, it's a great, like, this is like the beauty's in the eye of the beholder a little bit. There are a ton of people out there with a point of view of what makes a high performing, high quality, high value, doctor. Like, and I won't even, just like, we could probably fill a list of the names of people that have methodologies and systems, and they all, at Quest, at least, our view is, we want what our clients want. The people who are building a network, it's their point of view of what beauty is that we want to support. This is your kayak comment earlier, right? So if Jim or Steve A have sort of a point of view that this company's score and view of provider evaluation is the best, we're like, great. Like, we can connect that in our platform to things like, what are the office locations, and what is their basic claim volume? Like, are they participating in a line of business? And we can connect, so we can sort of enrich the file for the system that they find most beautiful. And honestly, most of our clients don't have a system. They've got a couple. Like they've got as Jim mentioned earlier, they've got the one that they've curated for the docs that they know. But then there's a whole bunch of docs that don't know. And so they need to use a third party. And so our view is beauty's in the eye of the beholder. What do you think is beautiful? Let's help you get there.
Hey, Steve, can I add just one point to that, Eric? I think that what we found often is a single source does not equal truth. And the more information you can combine together that may look like it's the same type of information actually creates an incredible amount of value. And having the ability to have a couple different frameworks around the same variable where you can confirm that the same provider looks excellent in a few different modalities creates a lot of confidence that the story is correct. And then we can use that from the insurance company perspective to communicate directly with the providers. I mentioned this in one of the chat questions. What we found is transparency and measurement is critically important. A lot of the measurement tools that have been used for decades around total cost of care or episodic cost of care, a little bit black boxish. Meaning you get a score that's an observed to expected, and provider A is a 1.2 and provider B is a 0.8. And it's really hard to unpack what's driving that difference. If you're not unable to unpack that difference, how does a provider understand why they're scored the way they are? So that transparency of what's driving is really, really important.
And Jim, when you talked about comparing the data sources and saying which is valid, and you need an aggregator like that Kayak, are you guys incorporating something like Quest Analytics into your whole provider network strategy?
Absolutely. It's a core component of what we're doing, and we're looking to feed as much information into that platform. To the point I mentioned earlier, Eric, the ability to have information in one single place unlocks an incredible amount of time efficiency in decision making. Okay. And so our goal is to pump as much information into like a Kayak as possible, so we can easily sort of see the decision making and scenarios around, if you click this one, what does that look like in total? So I'll expand on our Kayak analogy. You're not just buying a flight or a hotel, you're buying a vacation package. And as you're clicking on different elements of the package, what does that do to your overall experience and your overall cost?
Right. Steve Anderson, I want to come to you, get back to incentives, because I want to cover specialties, specialists. Before we do that, if you want, because we've talked a lot now, and there's been a lot thrown out here around sort of steps to build provider network and some interesting thoughts on how to reimagine your provider network strategy. I'd asked the team at Quest when we were preparing for this session to maybe put together some of the high-level things we're planning on covering. So if you want a bit of a summary of the steps that have been covered by all three of the panelists, the producers at Quest, they've authored this high-level kind of starting how to establish a foundation within your provider network, the key factors to consider when you're selecting your providers, and how to, all the things that you've heard us talk about or the group talk about. It's a great summary of some of the key components. And if you want a copy of that, I'll send it over to you after the show. We're going to cover some other things in the next 15 minutes or so that it's also part of the summary. So if you want the piece, I think we called it Reinventing Your Provider Network Strategy, the blueprint, I'll send it to you. It's a PDF. Just Gene, why don't you put up a poll, and anyone that clicks on yes, we'll send it out to them. Steve Anderson, how are you applying your primary care incentive program to specialists? Because I'm sure everyone's wondering about, especially.
Right. I just double down on what Jim said on that last topic. It is an iterative process. We went through a couple of different vendors and ended up building a minimally viable product for ourselves. And now we've are going into another engagement with a vendor. So finding the right one is really what Steve said, in the eye of the beholder. The other side of that, though, and this isn't going to answer your question, Eric, also, but is the member. The member has to get engaged in that decision making, and we're not seeing that uptick yet. We don't want to disintermediate the PCP. That is a really sacrosanct relationship, right? But the amount of data that we have and can guide that member through their health journey, their health quest, far outweighs that primary care physician. So coming alongside them with data is really what we're trying to do, which gets me to the specialists, right? Not all specialists are the same. Steve mentioned it a little bit there. You do have your big health systems. They employ a lot of physicians, and you always want those in your network. And then, we have a big member population. And so it's not like we can just pick the top 10% and try to focus our membership there. We will overwhelm those physicians. So we have a sort of dual strategy, if you will. One, identify the top tertile. It's a new word. I don't even really believe in it, but the top third of providers and high performing, and try to work with our physicians to focus referrals there, but then bring that second grouping up, work with them to expose them to the metrics that we are measuring them on. And, you ever shown a physician that he doesn't or she doesn't match up? You get instant interest and reaction and action into, well, let me show you how good I am. So then now we have 2/3 of the specialist population that we can work with. And it will be up to that last third if they want to figure out how to survive in the new world or go the way of, the Edsel. So for us, it's been about incentives. And really, we've put the power in the primary care physician hand. We've shown them who we think are high performers, but there's a whole nother aspect to that, and that is good citizenship. Are they good partners in the care? Do they return notes? Do they collaborate on the right facility? Do they hit the right side of care? So between our primary care physicians and our own data, we are incentivizing the specialty community to collaborate with us. And we started with the big ones, the big spend, cardiology, obstetricians, and some of those and you have to make it meaningful for them. It's not like for the primary care physician, how big we might be in his or her office. In the specialist office, we're smaller. So you gotta make it attractive and enticing. But really tying it back to that physician, because he or she might have a whole nother set of patients that they're referring, and that power to refer is what we found gets that specialist to react.
What's that kind of, you don't have to use an exact number, but what's the percentage to make it enticing?
Well, it's somewhere above 5, and the closer you can get to 20 is really where you 20% of whether it's the payment or gross revenue, somewhere in that space is where you really start to get their attention. But again, it doesn't even have to be totally incentive based. It could be all of my other patients that I refer as well.
And how's that funded?
It's funded through claims, through our professional fee schedule, and general bucket of money on how we reimburse physicians. Some years ago, we froze our fee schedule and started putting annual increases into an incentive bucket. And over time, that has grown pretty dramatically. So we have some serious funds to influence and motivate people to work with us and work with our primary care physician.
Okay, that's great. Hey, folks, one final PSA. You've probably already, if you check your inbox and your email, received yet another email from me just asking you for suggestions for topics for next year, how we did today, how we could become better. For those of you who are new to the show, we read each one of these, and it really just influences how we produce the show moving forward. It's how we've grown the show over 10 years to be one of the largest healthcare B2B podcasts and webinars out there. So we really thank you in advance for your 2 or 3 minutes of feedback. It's really important to us to make sure that we're providing better content for all of you listening. I've got 10 minutes left and 15 minutes of content. So let's see if we could, we're gonna start, Jim. I want to talk about a blueprint for everyone. I know you touched upon some of the things, but let's summarize the blueprint if someone's going to go into another market right now and build a provider network from scratch that's going to be innovative and successful and do some of the things that we talked about earlier, like competitive advantage. And then Steve, we're going to try to check to avoid potential fatal mistakes. So we'll cover that. And then with time, Steve, we had a question from the audience about transparency and coverage. I want to bring you in, Stephen A, at the very end. So go ahead, Jim.
Yeah, I think from a blueprint perspective, the importance, again, I'll sort of double down on data and insight and analytics, and not just information, but information that's actionable and, again, collected in a platform that you can use. I think the organizational willingness to kind of buck the status quo, sort of back to that bravery and courage concept. And then I'll use the word creativity. When you're thinking about a network strategy, it doesn't just mean that you might be designing a high-performing network or a network that has less providers in it than it has in the past. I think you can create kind of a network within a network. And so we're investigating pretty heavily the ideas around curated access. So as we use the same information and framework of performance that we talked about earlier, can we leverage benefit plan design, or can we leverage member activation or member engagement to direct care to that highest performing provider space, while still maintaining a broader network for emergent care that might be necessary? So I think you have to have a little bit of creativity in your thought process and approach in order to meet the needs of the consumer and the patient involved. I'm really excited about the possibility, as we have new sort of AI approaches where you can get in front of the member and patient maybe quicker than you have in the past. A member has an elective procedure scheduled. Can we go in and influence them relative to what we know about providers where they're geographically close to that member, and say, hey, if you go to this provider, you're going to have better outcomes, you're going to be home quicker, and you're going to have lower costs out of your own pocket. So beyond just kind of what I would say the traditional stripping from a network, there's concepts that you can begin to employ while you build kind of a network within a network.
Okay, let me see if I can quickly summarize that, because it's important. I'm going to add one thing. You didn't mention data and analytics, but you were assuming it, almost insinuating it. So I just want to make sure that's out there.
100%. That's the foundational. Like if you're building a pyramid, that's the foundational base of the pyramid.
Curated access. Can you quickly define that one more time?
Yeah, from my perspective, curated access is empowering your member and patient with information around the best place for them to seek care, given their emerging need at the time. And the ability to do that almost real time is new, and it's actually happening, which is kind of really exciting from an outcomes perspective.
And that's all enabled by the ability to tie disparate pieces of information together.
All together.
And you said the organizational willingness or courage.
Yep.
This isn't just asking providers to reduce rates. This is creativity and all that, and then the reporting and the
exactly right. I think we're beyond the point as an industry where we can ask providers to continue to take rate cuts. That is not a sustainable model with labor costs increasing, inflation. The perspective that you can limit a network and then ask that limited network to cut their rates, it's just not a workable model for sustainability.
Stephen L., some fatal flaws to avoid.
All right. I'm going to be fast, just like the round table. I think the network is like the shopping for ingredients in a meal. If you have bad ingredients, it's really hard to have a great meal. So when you think about shopping for ingredients, let's start with where am I spending my money? And Steve Anderson mentioned this before. Understand those specialists. Not all, there's certain service lines that are really a lot of money. And in those service lines is a huge dispersion in many cases between top third tile, I think was the word, and bottom third tile. So understand the place you spend money, and understand who's really good there. Focus there. And the second thing that's really interesting about success thinks about the linkage between the primary cares and the specialists, and make sure you're building something a meal that's gonna work as a total. The entrees and the main meal all connect. We're not going to the Southeast Asia for the entree and then coming to Chicago for steak in the main meal. Let's stick with the same menu.
Okay, let me see. So we got for the meal, we got to make sure we're looking at avoid the ingredients that are driving costs.
Yep.
dispersion between the good and the bad, because the stakes are high, no pun intended. And then you said sort of understanding, this is where the metaphor got a little confusing, but you meant referral flow, right? Where you just
Referral flow, primary care, specialists, bring them together.
think about the PCP as an output for those specialists.
They are a connected equation.
That's an equation. I love it. All right. Transparency of coverage. This is something that's come about this year. How is it impacting, Stephen A., I feel like I'm an ESPN now, your provider strategy, and how has the price transparency data pairs have been publishing over the last year impacted your provider networks and contracting strategy? Has it been helpful?
Yeah, it's getting complicated, more and more complicated, almost as complicated as Steve L's analogy there. I haven't had any of the systems on the low end of reimbursement, on the high end of reimbursement, call me up and say, hey, we want to give some money back to those guys on the low end of reimbursement. So that's number one. But two, we haven't found the data real helpful just yet. It's massive, it's incomplete, it's to a degree obfuscated by the payer and or the hospital producing it. So it's a little hard. And I think it matched up with most people's understanding of who's getting paid what already. But we have a lot of hope, not my favorite word, that transparency will drive down to the physician, and between physician and member, enable them to make better choices. We have some plans to negotiate more specifically, as somewhat of a leader here in terms of rates in the state of Michigan. We have a lot of people chasing us. We aren't chasing too many rates. So for the most part, we are trying to keep our advantage and keep those competitors in the rearview mirror. So it's more a little bit defensive. How do we keep our increases tied with what our competitors are getting? So all that to say, still early. The data not extremely helpful just yet, getting better. And I would like to see a world where we are competing less on unit cost and more on how are we able to work with the physician community to deliver better outcomes, better experience, better price for the members.
So in summary, the data is matching up with what you've seen. So it's not really helping just yet. It's almost like, but you do have hope that the transparency will drive down to the physician, ultimately enable them to make a better decision on the road. And as the data is getting better and this program continues, you think that you're predicting that in a couple of years, like this program will actually have an impact, but not yet.
Yeah, absolutely. I think we're starting to see the beginning of it, but I think there's big impact. But it gets back to an earlier comment. The member has sort of been lost at sea, right? In their journey, and they're not making. We haven't seen them make real informed decisions, and so transparency should ultimately empower and enable the member to make better decisions also.
It's great. Thank you. We're just about at the top of the hour. So thank you to our incredible roundtable, our panelists, for the time and the effort to prepare with me for today. And thank you for all of you who participated by listening, whether you're on a walk, listening to the podcast, whether you're watching live right now. And thank you for all those who watch live that submitted your questions, help me co-moderate. We hope you use the bright spots shared today to inspire your thinking and enhance your organization's current approach to improving healthcare for all of us. We produce this show for you. This is your Bright Spots in Healthcare podcast. Take care, everyone.